All right, to continue, this is the third video in your series of children with altered respiratory status. We are talking about cystic fibrosis. This is where we left off. This is an endocrine disorder. All right. It affects the lungs, pancreas, and sweat gland. It is the most serious lung problem of children in the United States. It is autosomal recessive. So what that means is there are 2 copies of the abnormal gene that are present. It's actually a CFTR gene. Both parents have to be carriers. So to start with, the symptoms of the lungs, and you can see there, obstruction of the bronchioles, barrel-shaped chest or club fingers. Remember, those things don't happen overnight. Those are a result of a lack of oxygen perfusion over long periods of time. Okay, you can see there the right ventricle will enlarge, higher risk of respiratory infections, chronic cough, dyspnea, wheezing, cyanosis, irritability, fatigue. All those are symptoms of cystic fibrosis to the lungs. This is what your lungs would look like with cystic fibrosis. So there, it looks like the alveoli and the bronchioles are filled with like gum. It's thick secretions, thick mucus, and more of thick secretions. Okay, makes it very hard to for oxygen exchange to occur. As far as symptoms of your pancreas, well, the secretion of digestive enzymes are blocked. So what that means is there are certain vitamins that cannot be absorbed because those enzymes are what helps break them down and helps with that absorption. You can see there, especially fats and proteins, so that is an issue. Steatorrhea, if you remember, this is when there is fat in the stool. That is because the child's not able to metabolize that fat. Okay, they are often malnutrition from their absorption issues. Their abdomen, is distended just like this, where they have a muscle wasting in their legs and an abdominal distension. The wasting is based off of the malabsorption. You can see there is atrophy. There could be atrophy. There is a failure to grow, and if we are talking about a failure to thrive, in this case we are talking about organic, right? Sallow skin, that is when skin has lost its natural complexion. It's usually yellow or brown. This denotes a vitamin deficiency. In Pennsylvania, children are screened for cystic fibrosis in their newborn screening. But remember that we talked about a long time ago where those newborn screenings, when we talked about ethical dilemmas, we talked about those screenings, those genetic screenings are not necessarily always accurate. So you could get a negative result or a positive result that are not necessarily accurate. But what will happen in the case of a suspected child with cystic fibrosis is they will do what's called a sweat test. All right, and this is a test that they make the child sweat and they measure the amount of chloride, so that's that component of salt, in a certain area. All right, depending on the number that they get for that chloride content, it will depend on if they think it's possible or if they truly do have cystic fibrosis. All right, you can see there the sweat glands, there's going to be an increase in that. All right, if there are positive gene markers for that CFTR that we talked about, they are going to do further genetic testing for mutations. Additionally, if they do the sweat test, they will again do further genetic testing. There are different types of cystic fibrosis, believe it or not. We don't need to get into that for our purposes, but that helps them treat this disease better. One of the first symptoms that will be present with a newborn is they will have a rectal prolapse. They have a rectal prolapse from the constant stooling and that malabsorption issue. All right, they may have liver cirrhosis, osteoporosis. Remember, cor pulmonale is that abnormal hypertrophy of that or enlargement of that right side of the heart. Okay, the meconian ileus, that only occurs in about 7 to 10% of all newborns. That's a bowel obstruction with that thick, sticky meconium. It blocks those small intestines. And frequent pneumonia. As far as overall physical exam, you can read down there. Obviously, we're going to do focus assessment in some of these areas. The rectum, we're looking for that rectal prolapse from the constant stooling. Diagnostic tests, we talked about the sweat test. Chest x-ray to help determine if there's possible pneumonia. Pulmonary function test to see what kind of function the lungs have. And like I said, after the sweat test, if it is positive, they would do more genetic testing. So how are we going to treat this? What are we going to do? Well, they're going to get oxygen. They get oxygen in an acute situation as much as they need. And then after that, remember, for maintenance, they get as much oxygen as they need to maintain their oxygen saturation at 93% or better, right? They may be on prophylactic long-term antibiotics. I've known children who had antibiotic pumps. Mucolytics, and we're going to talk about specific. There's one specific for cystic fibrosis, but this is something that will help thin secretions. Aerosol bronchodilators. You can see there we're going to do ACT, postural drainage, chest percussion, and breathing exercises. Okay. Postural drainage is usually done about 4 times per day. It looks like this right here where the child's head is lower. That is postural drainage. Chest percussion. There is a video that we are going to watch in class about chest, or we would have watched already, in class about chest percussion therapy. So you should have a good idea about that when we are in class. Good pulmonary hygiene. That's why we're using the vest and the flutter valve, and we'll watch those videos in class as well. Those just help mobilize, loosen up secretions so that the patient can expectorate them or hack them out, right? It is very important for cystic fibrosis kiddos to be up to date on all their vaccines and to do everything they can to prevent infections. All right, so let's be specific here about our medications. Our first medication of choice is going to be our bronchodilator. That is going to help open up those airways. So we want to do those short-acting beta adrenergics. And you can see the list there. So we're looking at albuterol, levoalbuterol. Those are the ones you're really going to see often. Albuterol is one of the cheaper ones, so you're going to see that. All of these raise the heart rate except for levoalbuterol, which its claim to fame is that it actually does not increase heart rate. So you may see this given, especially if there's another underlying cardiac condition, things like that. Then you would go to the cholinergic blocker, and you can see there the example is Atrovent. The hypertonic saline, that is given at 3%. We give that usually during a nebulizer treatment, and this helps thin out those thick secretions. The mucolytic of choice, which I alluded to earlier, is the Dornase alpha. This is cystic fibrosis specific. So this is an inhalant that they take generally twice a day. So if it's a multi-dose inhaler or if it's a nebulized substance, they do it twice a day to help decrease the viscosity of mucus. And what that means is decrease that thickness, okay? And then we have those inhaled antibiotics, which you might see. Now, you might be wondering, well, Mrs. Lewis, what about a corticosteroid to help reduce inflammation? Well, a corticosteroid is only effective if there is actually inflammation. So if in a normal child with cystic fibrosis, there is actually no inflammatory component. So a corticosteroid is not going to help them. So a corticosteroid, if they're acutely ill or they have an infectious process, would be very helpful. What order do you think we would do these in? Well, hopefully you're thinking to yourselves that we're going to do the bronchodilator first because we want to open up the airways and make them bigger. We would do one puff generally of a multi-dose inhaler, wait a minute and do another. If they are sick and you are using a corticosteroid, you would wait 5 minutes to let that bronchodilator work so that the corticosteroid is more effective. Then you would give the multi-dose inhaler for the corticosteroid for the prescribed amount. After the corticosteroid, that's when you want to rinse the mouth out, okay? If you're not using a corticosteroid, if it's just without any inflammatory process, we're talking about a bronchodilator. Then we're talking about the hypertonic saline, and that's a nebulizer treatment, so 10 to 15 minutes. Then we are talking about possibly that mucolytic if it's within those 2 times a day. You may have that therapy vest. Sometimes they're called TheraVest or ABI vest treatments. That's a half an hour treatment. It is a vest that vibrates the lungs to help mobilize these secretions, but it stacks up. So it starts out at a certain rate and then it stacks up for 15 minutes and then it starts to wind down and stack down. They might often also have a cougholator or cough assist, which simulates a cough for that patient and helps them to bring up the mucus. So usually they're only on this type of thing if they can't expectorate or bring up the mucus once it's loose in their lungs. As far as the malabsorption issue, our children with cystic fibrosis should be eating 1/2 to 2 times the normal caloric intake for their growth and development. So that means it's very calorie dense, protein foods, okay? They should not be eating empty calories of just crap because they really need nutrients in order to grow and develop. they typically need about 150% of the recommended daily calories for their age. Okay, these children will need salt substitutes most likely in the summer. And you can see there that we need to monitor their growth and development, their height and weight. We need to make sure we're watching their albumin, prealbumin, so we need to look at those to see the short-term and long-term malnutrition for that child. Check their glucose, their electrolytes, CBCs. They should be on oral pancreatic enzymes. These are capsules or things that you can sprinkle on the food that help with absorbing those fat-soluble vitamins, okay? And in more severe cases, they may need nutritional supplements, or they may have a feeding tube to help with their caloric intake, okay? Those pancreatic enzymes are monitored and adjusted based on weight. So basically, the family can monitor those stools, and this would be something you would have to educate about, but the more their stools become steatorrheic or fatty, then you would have to adjust those pancreatic enzymes because you know they're not absorbing those fat-soluble vitamins. Okay, and here is what you're normally going to see. The pancreolipase and the crease and the creon available in powder and capsules. Remember, you can sprinkle it on the food or you can take it right before you eat. And we are worried about the fat-soluble vitamins of A, D, E, and K, all right? We've talked about this very briefly when we talked about burns, but those medium chain triglyceride oils would be given to help increase that fat intake, okay? We would put them on an H2 blocker to help with any increase in stomach acid. Also, you may see Reglan given, and that will regulate how quickly the things will move through that digestive tract, all right? As far as support that we can, or interdisciplinary collaboration that we're going to use to help support the families, we want respiratory therapy to help and talk to them about all the respiratory treatments. It's a lot. It's a lot of equipment. It's a lot of treatments. This is something that they generally must do 2 to 4 times a day, every day, without fail. There is no skipping these treatments, all right? You can adjust them slightly. So, for example, let's say they go to school, they can do a treatment in the morning, they can do a treatment after school, they can do a treatment at dinner, and then before bedtime. So as their health allows, but they can adjust their schedule to help with functional living if their health allows that. Social services will help provide appropriate state and federal fundings. This is extremely costly for children, all right? All these things, extremely costly. So the family will need support with those things. And you can see their appropriate referrals. They will need to be going to physical therapy to get the most out of those respiratory muscles. They should be as strong as possible. All right. Child life services. So those might be tutors at a hospital if they're hospitalized long term. If they are very medically fragile, they might need educators to come to their home, those types of things, okay? We try to continue to keep our children on a good growth and development pattern so that they can continue to grow and develop, right? Okay, so as far as our nursing care, We need to monitor the response to the therapies. So are the therapies being effective? Are they doing them right? They're always going to need fluids if they're in the hospital. We're always going to need to measure the height and weight and see how they are growing. We will have to offer emotional support for the parent-child. We would have to help them with their growth and development. So if they're school age, that would include that kind of thing. If not, we're doing developmental activities that are appropriate for their age. Transplant is sometimes an option. It does not cure. We're talking about lung transplants. It's not a cure, but the healthy lungs that are transplanted are not affected by the cystic fibrosis once they are successfully transplanted. So that is amazing. And we're going to watch a really good video when we're together about that. It's one of my favorite videos, in fact. Their life expectancy for someone with cystic fibrosis is still about 37 years of age. That will be dependent on the type they have and their health status, their ability to maintain their health status. Some children are going to die much younger, unfortunately, and some are going to live. And you can see if you Google it, there are Skype support groups for cystic fibrosis kiddos. Not kiddos, I mean people in their 50s. So you'll see a wide variety of that, but that's their life expectancy. Their 5-year survival rate after getting a lung transplant is 67%. About only half the successful transplants live to 10 years and beyond that. So all right, so there are a lot of things in the community we need to think about when we're talking about children with cystic fibrosis. They will have lots of restrictions. For example, they cannot yet within 6 feet of another child or person with cystic fibrosis. So they must stay 6 feet apart. Even when they have fundraisers, they have to wear a pin marking those with cystic fibrosis, and they have to stay 6 feet apart from each other. The issue is they very easily transfer their infections and bacteria to each other, and they're very susceptible to certain ones. For example, the bacteria strands for Burkholderia are very susceptible to. The ones you are going to hear a lot of are B. cepacia. So that's Burkholderia cepacia. And that is a type of Burkholderia resistant to antibiotics. And it's a type of bacterial found in soil and dirt. But they are at high risk for respiratory infection for our cystic fibrosis patients. Anticipatory guidance for cystic fibrosis children are going to center around health promotion, including vaccinations, hand washing, staying away from sick people. You can see their adolescence, there are a lot of issues. It is very difficult for them to transition into life or adulthood. If you think about it, when you graduated high school, you thought about all the things you might want to do, right? Well, cystic fibrosis patients don't have that option. So if you have cystic fibrosis, you're not going to be able to work in healthcare where there's bacteria infection all over the place, right? Because you don't have a healthy immune system. You cannot be around that. It will make you sick constantly, right? So they have to be very careful on the types of careers they pick, and maybe they, depending on their health status, can't go away to college. Maybe they have to do an online program. So those are all things that they're going to have to consider in their adolescence. this puts a lot of stress on the family, but it is also very stressful because statistically these children die before other children their age with healthy immune systems without disease. So the children with cystic fibrosis, that end of life care is something that would have to be discussed with the family, okay? There is a movie that is pretty good if you are interested in cystic fibrosis and want to see a decent movie. It's a, what is it, a drama romance maybe, called 5 Feet Apart. And this is two people who have cystic fibrosis who decide to take that 1 foot back. So they're trying to gain that autonomy by taking one of those 6 feet back. The movie was based on a real person. The person was a famous video blogger. She blogged about, or I should say vlogged, but I don't really like saying that. Anyway, she would give talks about disability and how that just because somebody has a disability or has a different life based on their health status does not mean that they are not living and living fully. All right. Everybody's idea of that is something different. Unfortunately, I believe when she was 21, she had a lung transplant that was not successful and she passed away. So, but the movie is pretty good if you are interested. We are going to go over NCLEX questions in class to help support this lecture. And that concludes this lecture series.